My name is Adva Vilchinsky. I'm the Consul for Public Diplomacy at the Israeli Consulate in New York. So first of all, thank you for joining us. We're all facing, I think it's a unique time in the history, for good or bad. We're all facing the same challenges. A big challenge called COVID-19, already with us in part of the world more since December. Here in New York, since the first case was discovered in March. The Israeli consulate in New York is doing a lot of efforts to work with our friends and colleagues in New York and the region to address the challenges of COVID-19, if it's with public diplomacy, with supporting different communities, with having activities, with sometimes even, sending food to hospitals. And this effort, which will be the next webinar that you all be joining us, is another aspect of the relationship between Israel and the US and New York, trying to have more of academic discourse and academic cooperation. If it's in the level of the students, if it's the level of the faculty and administration. And I think this unique webinar again demonstrates the uniqueness of this crazy disease that just controlled our life in the past few months, and we don't know for how long in the future. A disease that affects everyone, rich and poor, healthy and not so healthy. I think that the webinar today is focusing the low-income society because, like many other things, those are usually the more affected population, if it's physically, mentally, and financially. And to have the discussion as interesting as possible, we have our moderator today that I will have the honor to present. We are pleased to work with the University of Columbia and with Dr. Michaela Martinez, already the second time working with us and building bridges between the countries. So Dr. Michaela Martinez is Assistant Professor of Environmental Health Sciences at Columbia University. She earned her PhD in Ecology and Evolution in 2015 at the University of Michigan, followed by 2 years at Princeton University. Her primary focus is understanding the drives of seasonality in infectious diseases system and the impact of circadian and seasonal rhythms on disease. Her lab as well is researching and focusing the immunity transmission and racial inequalities in COVID-19. So thank you, Dr. Martinez, and I wish you all an interesting 1 hour that we could all learn and use this knowledge for next days, weeks, months, and much more. Thank you.
Thank you so much for that introduction. And I would like to welcome everybody today. I'm quite excited about the lineup of speakers that we have. And today we are going to be discussing non-infectious diseases and their impact in the COVID-19 pandemic. And to kick it off, I would like to introduce Dr. Mark Clairfield. He's a Director Emeritus at the Medical School for International Health. In the last 2 years, he has served as a visiting professor in the Department of Medicine at the University of Gondar Medical School in Gondar, Ethiopia. His research interests include aging, Alzheimer's disease, and related dementias. He earned his MD at the University of Toronto. And with his long legacy of experience in working with non-communicable diseases, he is going to share with us how his work has intersected with COVID-19 in this pandemic. And with that, I will turn it over. Oh, it looks like we need to unmute you.
I'm sorry, I think I missed what you said.
Oh, there we go. Now you're unmuted now.
I'm unmuted. Okay, I'm going to share a screen. Then here we go. Let's hope this works. Oh, I'm always so impressed when this works. You can see me, you can hear me, you can see the slides?
Yes.
Great.
Great.
Okay.
And oh, just one last thing. For anybody who has questions on the presentation, please add them in the chat box, and I'll be monitoring the chat box throughout.
Okay, so thank you, Dr. Martinez, for that gracious introduction, and also to the consulate in New York for organizing this day, and to my fellow speakers. So I'm going to try in 9 minutes to talk to you about the subject of non-communicable diseases in low-income countries, a special challenge. And the first thing I have to do is say that I don't have any relevant disclosures for this talk. And really, I can give my talk in one slide. My take-home message is there are more and more older persons around the world. And as a result, there are more and more NCDs, non-communicable diseases, to prevent, diagnose, and treat. That's it. If you want to go to sleep now for the next 10 minutes, you've heard my talk. I'll try to add a little bit of color to that. The first thing is this is good news. It's good news that the percentage of people over age 65 is more than the percentage of children under age 5. When I was born in 1950, you could see that there are many more, the world was full of many children and very few old people. Things have changed since then. Here's another way of looking at it. This is the population pyramid. This is 1950 when I was born. Let's look at people over age 70. In the dark blue corner, that little triangle, that's the number of 70-year-olds there were in the world then. Today, let's go to 2018 and look at the area under the curve. It's a much, much bigger group of people in the world that are over age 70. And I very much intend to live to 2100. And so you can see how many people over age 70 are going to be around when I die 80 years from now. There are going to be a lot of us. Another way of looking at this more simply is simply that the life expectancy at birth has gone up 10% in the last 20 years. That's an amazing accomplishment. So really, we have what to celebrate. What people often think, this is number of people over age 60. The red here is LICs, low-income countries, and the pink is wealthy countries. And you can see that even today in 2020, there are many more old people in the LICs than there are in the wealthy countries. We think of aging as a problem of the wealthy countries, but the absolute number in poor countries is quite high. And it's just because their numbers are relatively low because of the number of children that we have this mistaken impression. So there are a lot of old people around today, and there are going to be many more of them tomorrow. That's because countries go through what we call the demographic transition. We start off with a high death rate, a high birth rate, and then they fall. And as they fall, because the death rate falls and the birth rate falls more slowly, we have a rise in population, and these people get older and older and older until we have a leveling off. So this is where Israel is today, and this is where Ethiopia is today. And Ethiopia is going in this direction, and all the LICs. Now, the cost, in quotes, of old age, it's not that old age causes all these diseases, and if you get old, you'll have them all. But we know that these diseases are much more common. These non-communicable diseases are much more common in older people. And so the more older people you have, the more prevalence you'll see of these diseases. And what we normally say about the LICs is the low-income countries suffer from acute infectious and mother and child diseases, but they also suffer from or enjoy aging and suffer from non-communicable diseases. So they have what's classically called the double burden. But my friend, Dr. Shitayu, whom you'll hear in a few minutes, she said, we in Ethiopia, in the LICs in sub-Saharan Africa, we live under a triple burden because we not only have acute disease and aging in NCDs, we also suffer from an inadequate, disorganized healthcare service. Underfunded really would be the best way to put it. And unfortunately, under the stress of COVID, we see that this characterization is not just true of LICs, it's true of some of the richest countries in the world. When you press them enough, they're also inadequate and disorganized. But we're thinking today about LICs. We normally think that chronic disease is true of wealthy countries, but not of poor countries. But here we have an old man in Ethiopia. Here we have the chronic diseases clinic in the Gondar Medical School with the professor and the residents and the older woman. I saw a lot of old people in this clinic. So we do have older people in LICs. As an example of an NCD, a non-communicable disease, and what's happening, let's look at diabetes. The red is 2000, year 2000, and the blue is 2030, a mere 10 years from now. Let's look at sub-Saharan Africa. In the year 2000, there were 7 million diabetics in sub-Saharan Africa. By 2030, there'll be almost 19 million, 250%, 162% rise in the number of diabetics, the number of people suffering from the NCD of diabetes in sub-Saharan Africa. In our part of the world, in the Middle East, the number is also 160%. Everywhere you look in the world, these are going up. And I don't have time to go into it, but I think most of the audience will know why that's happening. So there are 46 million older persons in sub-Saharan Africa. And in a WHO report, they showed a really interesting graph. And what they showed is, this is age group, young, middle-aged, old. On the y-axis is percentage disabled. The higher the number, the more disabled. So not surprisingly, you see with age, the percentage, the prevalence of disability goes up, but there's a big difference between wealthy countries where it doesn't go up as quickly and poor countries where it goes up much more quickly. So they have old people in LICs, but they're sicker. So that the average, my mouse is not working, the average 65-year-old in sub-Saharan Africa has the same function as a 75-year-old in a wealthy country. Simply translated, older people get older sooner in poor countries or in poor communities. It's the same in New York. We'll hear from Dr. Schluger. Poor people get older faster than rich people. Here's a busy slide, but all you have to look at is the color. This is mortality, Ethiopia, 1990 and 2016, pretty well today. And you can see that back in 1990, ischemic heart disease was the sixth most common cause of death, followed closely by stroke. 20 years later, 30 years later, these numbers have gone up. Just look at the blue in this slide. The blue is NCD's mortality. And look at the blue in this slide, 20 years later. You can see that the blue has moved up. The rising tide of old age has moved all the NCDs up in the ranking of causes of death. So even in a poor country like Ethiopia, ischemic heart disease is now the third cause of highest cause of death. Ischemic heart disease in a poor country full of children. Hang on a second. Okay, how well prepared are the LICs for aging and NCDs? Well, we've already discussed the underdeveloped healthcare infrastructure, and insofar as it's developed, it's designed for acute, not chronic disease. Almost no foreign aid goes to chronic disease. 97% of foreign aid in sub-Saharan Africa goes to acute disease, and none of it goes to older people. There's very little formal education in my field of geriatrics or in cancer or NCD. There's more in cancer and NCD, but there's nothing in geriatrics. And I found when I worked in Gondar hospital, the doctors there were very skillful, and they told me that they saw a lot of people, and I saw old people, but they said that even though they saw them and looked after them as best they could, they didn't have much education in how to do it. And that's, of course, that's a problem. There are very few doctors in sub-Saharan Africa. There's one doctor per 40,000 people in Ethiopia. Compare that to one doctor per 330 in, say, Israel or the UK. It's a little higher in the United States, versus one traditional healer for 500 Ethiopians. So it's no surprise that an Ethiopian person, when they get sick, will find it easier to go to a traditional healer than to a doctor, just because there are very few doctors and a lot of traditional healers. So it's no surprise when people get sick, they go to the church and they drink holy water. And I'm not saying this in a mocking way. I'm not saying this. I'm saying that if there were more doctors, people would come to them sooner, and they would not take holy water for malaria or hypertension. And maybe Dr. Shitai can speak to this later. There has been some progress. This is a family. This is diabetic health promotion in a community outside of Gondar. This is health promotion information on the campus of the Gondar Hospital. Here's Dr. Shitaya, and this is the waiting room halfway through the clinic. The clinic starts at 2 o'clock and ends at 5, and this is at 1 o'clock and ends at 5. This is at 2:30. And 2:30, the place is still pretty full. We've already gotten rid of half the people. Yes, Michael, I'm almost
Dr.
finished.
Dr. Clarkfield, you have 1 minute remaining.
Thank you very much. Okay, so they do have, thank you, they do have high blood pressure programs, but only 3 of 100 hypertensives are controlled in Ethiopia. They know about NCDs. This is from the Mekelle University website. They mention NCDs. There is an NCD program from the Ministry of Health, November 2018. So my take-home message, there are more older persons around the world, especially in low and middle income countries. As a result, there are more NCDs to diagnose, prevent, and treat. So I thank you, and I'm glad I was able to keep the time. We'll have time for questions later. Here's my email. If you have any complaints, you can send them to me afterwards. Well, thank you very much, Dr. Martinez, and I'll stop sharing, right?
Yes.
I'd like to share, but I'll stop sharing. Okay.
And we will go to our second speaker, Dr. Neil Sugar, who is currently the chair of the Department of Medicine at the New York Medical College School of Medicine and the director of medicine at Westchester Medical Center. He is the founding director of the East Africa Training Initiative in Pulmonary Medicine, and he was a past president of the American Lung Association of New York.
Thanks very much, Dr. Martinez, and thanks very much to the Israeli consulate for hosting this meeting. Let me just get my slides there. Yeah, you can see. That's good. Okay. Okay. What I'd like to do is talk to you a little bit about the interaction between COVID-19 and non-communicable diseases. I'll use New York City as an example for most of what I'm talking about, but then make a little bit of reference as a transition to Ethiopia, which is a place I've been working for about 10 years to help build physician capacity in that country. As everyone knows, I'm sure by this time, we are in the midst of a terrible global pandemic of COVID-19 that began really at about the beginning of the year. The first case announced to the world on December 31st, 2019, and then cases really in the mid-spring started to skyrocket. And you can see on the map on the right, there's really no place on earth that has been spared this pandemic. And as of yesterday, when I made this slide, was estimated by the investigators at Johns Hopkins University that there were over 40 million cases and over 1.1 million deaths around the world from COVID-19. But one of the interesting things we learned early in this epidemic in New York and other places around the world was that there are several underlying conditions, things that Dr. Clarkfield has already referred to, as well as others, that seem to increase the risk of severe illness with COVID-19. And they include cancer, chronic kidney disease, chronic lung disease, certain heart conditions, people who are immunocompromised for a whole variety of reasons, people who are overweight or obese, people with sickle cell disease, people who smoke cigarettes, and then people with diabetes mellitus, adult onset diabetes mellitus. So we know that these are conditions that increase the risk of severe COVID illness. And I want to show you how this works in a city like New York as an example. So here in New York, from the beginning of the pandemic until just yesterday, it's estimated that there have been, and I think the data here are pretty solid, about 250,000 cases of COVID-19 illness, just under 250,000, and about 20,000 deaths. And you can see the pace of the epidemic in New York City since the early spring. This is the number of patients newly hospitalized each day. So we reached a peak at about the beginning of April, when New York really was the epicenter of this epidemic in the entire world. And since then, there's been a marked decline in hospitalizations in New York, a little bit of a rise in the last couple of weeks, but nothing like what we had in the spring. So this was the COVID situation in New York. And what I want to look at is who got sick in New York. If you look at cases by race and income, you can see that the rate of cases, not just the number, but the rate per population in different ethnic and socioeconomic groups is shown on this slide. And you can see there's really increasing rates of COVID illness among Black or African American New Yorkers and Hispanic and Latino New Yorkers, really where you get to levels that are twice as high as they were among Asians or whites. And similarly, if you look at COVID case rates by income, you can see that rates are higher in poorer people than they are in wealthier people in New York City. So what's going on here? What's the relationship among all these things? Chronic disease, race, income, COVID-19. So I'm just going to show you a couple of pictures, maps of New York City, and I want you to keep these pictures in your mind as we go through. So this is, you don't have to really know too much about New York City, just look at the colors here. Darker colors are where there are more COVID cases on the left and more deaths from COVID on the right. So you can see that this is Manhattan here, separated by the East River, the Harlem River. This is the Bronx, so much higher rates of COVID illness and death in the Bronx compared to Manhattan. Parts of Queens and central Brooklyn, much higher rates of death and disease. So just keep that mental picture with you as we move through these slides. Here are maps that show you rates of diabetes and obesity in New York City. Diabetes on the left, obesity on the right, and you can see darker colors mean higher rates of obesity and diabetes, and it looks quite similar to the picture that I showed you of COVID case rates and COVID deaths. So there seems to be this association with these diseases as well. Similarly, hypertension, high blood pressure, high rates, here in the Bronx and central Brooklyn and parts of Queens. And the same thing for smoking rates. The highest smoking rates in New York tend to be in places that you've seen some of these other risk factors and illnesses as well. What about dietary patterns? On the right, sugary drink consumption. This is the one of the sort of the dietary equivalent of smoking cigarettes, I suppose. So sugary drink consumption, highest in neighborhoods where you remember that we had highest COVID rates, highest diabetes rates. Healthy food patterns here, the picture is sort of reversed. The healthiest people are in places where the rates of COVID death and illness were lower than they were for these other things. So as you see in these last several images, COVID illness and death seems to map very closely in New York City to places where you have high levels of diabetes, obesity, smoking, high blood pressure, and unhealthy eating patterns. What about looking at income? Again, here's the case rate for COVID on the left, an income map of New York City on the right. So the darker colors on the income map are the poorer sections of the city, and you see that there's really a relationship there to COVID case rates and COVID deaths. So darker rates here are higher COVID deaths, darker colors here are poorer sections of New York City. Adding this all together in a way, if you look at something called the Social Vulnerability Index, which is a measure that the Centers for Disease Control and Prevention use to assess vulnerability related to a number of factors in many different domains. The Social Vulnerability Index includes 15 variables in 4 domains: socioeconomic status, household composition and disability among people living in households, minority status and language, facility with English, for example, and housing type and transportation. So again, if you look at social vulnerability, you can see that it maps quite closely to where we had high rates of COVID death in New York. So what I've tried to do in this part of the talk is paint a picture that shows you that COVID just didn't come out of nowhere to cause the amount of death and disease that it did. In a sense, it took advantage of underlying social, behavioral, and medical factors and disparities within New York City to really cause as much disease as it did. Now, as Dr. Clarfield pointed out, non-communicable diseases that create this vulnerability to COVID are on the increase all over the world. 1990 and 2019, the percentage of illness due to non-communicable disease, you can see blue means more, red means less. So the color of this map in the 30-year period has gotten much more blue and much less dark red. And so the percentage of illness around the world due to non-communicable disease is growing, and that's shown here as well. Less communicable disease, more non-communicable disease around the world. And so that will lead me to sort of segue into Dr. Shataya's talk and just give you a few comments about Ethiopia, which is a place I've worked in for the past 10 years. It's a very large country, the second largest country in Africa. It's a poor country overall with low GDP, although a rapidly growing GDP. Life expectancy is still a bit below the global average, and relatively high fertility. The resources for healthcare, as Dr. Clarfield pointed out, are limited. A relatively small percentage of GNP goes to healthcare. Most care is supplied by generalists throughout the country. And as was mentioned, the ratio of physicians to population in Ethiopia is extraordinarily low, 0.02 per thousand. So that's 1/10 of what it is, 1/10 to 1/40 of what it is in other neighboring countries in Africa, much less than the ratio of physicians to population in Israel. I just wanted to mention, we've tried to make our contribution here through something called the East Africa Training Initiative, which Dr. Martinez mentioned. And through this, we've trained a whole cohort of pulmonary doctors who've come in quite handy, I have to say, during the COVID epidemic. Us appreciate, you see this from the Ministry of Health, an expression of appreciation to the pulmonary physicians in Africa. And maybe we can get into this a little later. So what I'd like to leave you with on my last slide, I've tried to describe the fact that COVID seems like an equal opportunity disease, but it really is overlaid on a foundation of chronic illness that is very inequitably distributed in society in the United States and around the world. So as someone has said, we are all in the same storm with COVID, but we are not all in the same boat. And so I'll leave you with that and can take questions now or later and turn it over to Dr. Shataya.
Thank you so much for that. And we will actually leave questions to the very end. All of the speakers will be coming together at the end to form a panel, and we will address some of the questions that are in the chat. And with that, I want to introduce Dr. Shataya. Dr. Shataya is an Ethiopian physician and academic. She pioneered diabetes care in northern Ethiopia. She's an expert in non-communicable diseases, and she has published on diabetes, epilepsy, HIV, and AIDS in rural Ethiopia. She is a professor of internal medicine in the College of Medicine and Health Sciences at the University of Gondar. And with that, I will turn it over to Dr. Shataya. I'm actually not seeing her video on. Let's see. Oh, here we go. Great. Wonderful. So the slides are working and I'm not getting any audio yet. Dr. Shataya, are you on? Bear with us for just one moment. I believe that she's having to connect through a mobile phone. If you can press the unmute option. Yeah. Wonderful.
Okay, I do now. About sorry.
Oh,
sorry,
no,
let me try again.
Oh yeah, it's okay. So the slides were up a second ago.
Yeah, how about now? There.
No, right now. No, right now we're not getting any feed from you. We can hear your audio.
Let me do it again.
Okay.
Let me do it again.
While Dr. Shataya is pulling up her slides, if
I will
anyone needs to take a 1-minute break, we can do that so that she can have the time to get her slides up.
Share screen. Option button. Yes.
So right now we can see your home screen, and then
Okay.
perhaps if you click on that presentation that's at the very top, is that it, the NCD talk?
Yes, yes.
And then hopefully that will pull it up. Yep, great.
Oh.
And then on here, it had it up.
Oh. It's not coming. How about now?
No, right now we are not seeing your shared screen.
Oh my goodness.
Now we're seeing it. So we're great so far. And then I think if you go back to where it had all of your PowerPoint slides.
You see?
Yes, great. And then I believe if you click on the very top one, yep, now we're great. And we can see it.
So can you hear me now?
Yes, and we can hear you.
Can you hear me?
Yes.
Yeah. Thank you very much. Thank you very much. I'm very much grateful for your kind introduction. I'm also very much grateful for the speakers who were before me, because they have really made my job easier. And this time I'm going to speak on non-communicable diseases in Gondar, Ethiopia, what we have done in the past 3 decades. And to go back to the beginning, the Americans who founded the hospital and the university, 66 years ago as a response for a malaria epidemic, found out that there are some diabetic patients, type 1 diabetic patients from the rural Ethiopia. These are subsistence farmers, very poor people, and who became poorer because of type 1 diabetes. They diagnosed them, started them on treatment, but they didn't want to send them back home because they could not imagine that these people would be able to handle diabetes with sterilizing needle and syringe. There was no disposable needle and syringe then, and also injecting themselves daily. So what they did was every diabetic that is diagnosed was supposed to stay in the hospital, and they were given non-menial jobs that they can do without training. And they did those jobs. And there were about 30 of them when I came 30 years ago. There is only one remaining at the moment working in the laundry. And when the number increased, there was no possibility to really employ them anymore. So they were sent back. They had to travel days, in some instances even a week, to come and collect their insulin. And because there was insulin shortage, they were not able to get long-term insulin. So they spend their times coming and going, and their farm is not farmed, and their lifestyle is totally disrupted. So they remained as beggars and daily laborers in Gondar town. And seeing this, we really tried to bring in treatment nearer to the homes of these very poor patients who were made poorer by type 1 diabetes. So we had a project which we call Gondar Diabetes Project, ran from 1994 to 1996. It was fully funded by a London-based non-governmental organization, which is Tropical Health and Education Trust. So we registered all patients, and put them to the clinic nearer to their homes. And there were 5 health centers all around the hospital. And we tried to run the clinic nurse-led, and we also trained the laboratory technologists. We put in small library at the site, and the clinic were completely run by nurses. And we go from the center to the clinic, initially every month, later on every 2 months, and later on every 3 months, only for supervision. Now, in this project, patients' attendance increased, displacement stopped, survival of diabetic patients improved. All the centers were upgraded in the care of diabetic patients because insulin was not in the drug list of the health centers. So with our negotiation and trying a lot and convincing pharmacists and higher officials, we made it possible that insulin should be available in the health centers, and the health centers started providing insulin and oral hypoglycemic agent. The work relationship between the health center and the university hospital improved, and consultation for other cases were carried out. So when we go out for diabetes, I usually get consultation for diseases like heart disease, mainly rheumatic heart disease with its congestive heart failure, hypertension, epilepsy, and asthma. So we tried to include those diseases and wrote a bigger proposal, and we included also another university in the south, Ney University, to work with us so that we can compare our work, we can compare also disease pattern and other things. And we got a UK lottery fund, we bought a vehicle, and we started the project and ran it for 5 years. This time we have included hypertension and heart disease, epilepsy, and diabetes, of course, type 1 and type 2, though type 2 is very rare in the rural village. Clinics were running for every 2 months, then every 3 months. Now, great number of patients benefited. All attempts was done to make the work interdisciplinary, and we managed to attack the surgical department. We did a survey on physical and sensory disability in Dabat region and came up with striking result. Most disabilities are preventable in the low-income countries, and the rest are treatable. So the idea of setting up a physiotherapy unit was raised, and a small unit was opened. And 2 nurses were later on trained to be physiotherapists. And thanks to people with vision, this is the basis for the only physiotherapy school then in the nation, and it's now producing physiotherapists and physiotherapy instructors. In fact, they are even instructors in other areas as well. Now, what is the present status of the project? It's still going on strong. We secured a 2-year grant from International Health Link Fund scheme and administered by the British Council and set for 3 terms. The first term, we used it to train community health agents on non-communicable diseases, just only to recognize patients and bring them to treatment, and that worked very well. In the second term plan, we included respiratory disease, chronic respiratory disease, because earlier on we started with asthma, but because asthma is a seasonal disease, the follow-up of patient was not very satisfactory, but now we started with chronic obstructive lung disease in the second half, and in the third, we go on to cardiovascular diseases and stroke. And in the meantime, also with training of the health extension workers, we increased our sites to 11 sites. So these are the number of patients that benefited, nearly 8,563 patients, and these patients are seen continuously in the follow-up of patients. At present, out of the sites, 5 have primary hospitals. Patients are shared between the hospitals and the health centers, and around 10 papers on diabetes, mainly on taking care of rural patients, malnutrition and diabetes, chronic complication of diabetes mellitus, and also lately on the pathogenesis of type 1 diabetes, because it's always our question. Our patients appear very late. They are diagnosed between the ages of 25 to 33. And this is unlike in high income countries or the middle income countries, whereby you find most of the type 1 patients below the age of 50. So we had a number of questions that we asked. Are these really type 1 patients, or are these patients that are type 2 with severe manifestation, or is there any autoimmunity? How about genetic predisposition and so on? So we were able to do that and come up with a result. 5 papers on epilepsy, caring for rural patients, and treatment outcomes, default and cause of default, and 1 paper on physical disability in Dabat region. Ongoing work, we are working on hypertension in diabetes patients, dyslipidemia in newly diagnosed type 2 patients, neuropathy in diabetic patients, and foot ulcer in diabetic patients. The problems encountered are high turnover of staff, shortage of drugs, mainly insulin. Government is not ready to hand in the project, and not enough attention by the government for non-communicable diseases in general. And with the addition of COVID, I 100% share what my colleagues said, and things are worse because some of the things that we attained, we are going back because of COVID. And our future needs are that we need to really work a lot on non-communicable diseases because they are increasing, and we have seen the graph quite easily. Now, future needs, Ministry of Health reform has expanded primary health care service. So a strategic plan for non-communicable disease is developed. Programs will develop shortly. We are in the right track, but we need to act immediately as we are standing on a time bomb. So I have acknowledgement to these organizations. This is the old Land Rover that we were using on a gravel road to go to the 11 health centers that we have patients in. And these are my patients. As you can see, I was younger, and there are 2 nurses around here who were running the program. This is the same time. Here is how patients take their drugs from the pharmacy. It's always overcrowded. It's always, there's always shortage. How the patients were given health education before the clinic starts. And you can see also our Land Rover behind. And this is how we work with collaborators from other countries. This young doctor is a collaborator, and he worked with us for some time. And he was visiting in one of my rural clinics. And this is the same nurse, and coach his skill. He used to coordinate interactivities. He's operating the retinal camera, doing retinal photography for patients. He was a diploma nurse, but we support him to train to BSc nursing and later on MPH. And later on, we managed to collect the patients and come up with diabetic association. As you can see, we have a big number of number of people attending to our diabetic association. The takeaway message is non-communicable diseases are major health threats in resource-poor countries. Their presentation and care is highly modified by poverty. Decentralization of care with proper leadership reduces the burden from referral hospitals and brings care nearer to the patient's home. Involving mid-level health workers and the patients is the backbone for the success of this work. Thank you very much. Hello?
Thank you very much for that, Dr. Shataya. And with that, I think we will have all of the speakers move to this last 10 minutes into a panel discussion where we can take some of the questions from the audience. And some questions are particularly directed at individual speakers, and then others are more general. So I'm going to pull them up here. So one of the running threads across all of these talks was that poverty is really exacerbating the effect of some of these non-communicable diseases. And just a question to all of the panelists, how do you see essentially low-income countries, the problem of poverty in these diseases is different than what we're seeing in, let's say, New York City, but there are some similar threads. And so how do you think that the healthcare infrastructure, or maybe federal governments, kind of learn from one another in terms of the experiences of how poverty exacerbates these issues?
Neil, you want to go?
Yeah, I'll say something maybe in the context of a place like New York. You know, in general, obviously New York is a wealthy city in a wealthy country, but there are many poor people in New York. And as I tried to show you, COVID is a worse disease in poorer neighborhoods. And there's no question that the reasons for that are many, but include, I would say, several of the following things. One is in terms of underlying health conditions. You know, we know, I showed data about access to healthy food and consumption of sugary sweet beverages. So healthy food in places like New York is more expensive than unhealthy food. And we know that many people live in so-called food deserts where it's difficult to gain access to healthy food. And so you have issues like that. The second is that Dr. Shatai was pointing out the need to provide good care to diabetics. It's still true in many parts of the United States that healthcare for chronic illness is much less available to poorer people. So I think that's one way in which poverty manifests itself. So even in wealthy countries, I think you have a lot of underlying conditions that really create a lot more vulnerability for poorer people, whether, as I said, it's lack of access to healthier food or lack of access to chronic health conditions. It's interesting. There are data to show in New York, once people got to the hospital, survival rates were pretty much the same for people of all races and income strata in New York. It's just that people who were poor, or people who had underlying, or from minority communities, let's say, that they were more likely to get sick in the first place. So once healthcare could be provided, it seems to work, but the underlying vulnerability to severe infection was so much greater because of the social and economic disparities that lead to a lot of the health disparities. That's what I would say.
Dr. Martinez?
Well, I was going to ask Dr. Shataya, do you have anything to add on specifically about how poverty exacerbates this issue within Ethiopia? Oh, actually, you're muted.
Yeah.
Oh, there we go. I believe you're still muted. Let's see. Has to unmute. Dr. Shataya, could you unmute yourself? Oh, there we go.
Yes, I did. Yeah, in Ethiopia, it is an absolute poverty. There is no food. It's not the quality of food. It's not the healthy eating that we worried at. There is no food. So I think unless poverty is taken care of, I don't think people would really tackle the burden of NCDs or any other disease, as a matter of fact. And fortunately, we don't know the reason, but fortunately, there are many speculations. COVID is not as serious as it is expected. Now, if you ask me my scientific expectation, COVID should wipe us Earth. But it's not happening. My hospital, There are a number for us not to know why that happens, and it's the scope of this presentation to discuss that. So I think the government to alleviate poverty. Unfortunately, COVID set us back with our trial to alleviate poverty and also to increase awareness on non-communicable diseases.
Thank you for that. And then I think we can move on to a couple of the other questions in the audience. There was one question particularly about social vulnerability and whether there were sex differences in social vulnerability between our women, particularly higher in the social vulnerability index or not, and how that plays a role.
Yeah, those are very good questions. I didn't have time to really go into these things in depth, obviously, as we were trying to get through the presentation. Social vulnerability, there are, I think, elements of social vulnerability that would place women at greater risk. There are elements of social vulnerability that might place men more at risk. As I mentioned, they're really in the CDC's social vulnerability index, there are 15 variables, and some of them one would think might not be gender driven as much, but some of them would be. And that's true for some of the things that lead to vulnerability or chronic disease in general. Sometimes in ways you would expect, sometimes in ways you would not expect. I mean, smoking rates in most places in the world are higher in men than they are in women. In the US, it's roughly the same, but in Asia, men smoke at vastly greater rates than women. So